All right, so why don't we carry on from last time? We were talking about the metacarpophalangeal joints. So, Michael, what do you think of this case?
A 33-year-old female with pain for 2 months. So I'm looking at, I don't know if something's going on with that second digit right up there, like we're looking at the sagittal band. That aspect of the sagittal band looks like it's gone, and that might be it pulled down. So the sagittal band's been torn, and then it also, I don't know if that's just kind of how it's coming over the flexor tendon.
It's not too displaced there.
No, the extensor tendon looks like it's in place, but I'm sure it's subluxated.
So it turned out to be a partial tear of the sagittal band there, but that's where the symptoms were. So you can kind of divide sagittal band tears into several different types. So I think from our standpoint, we just see increased signal intensity, and sometimes it's hard for us to determine really the full extent and what layers the tear goes through. So basically what I see is you get increased signal intensity within the sagittal band, really on either side of the extensor tendon, and then you look to see whether the extensor tendon is centered. If it's centered, since the forces typically will pull it to one side or the other, then it's probably going to be a partial tear. If you see increased signal intensity and the extensor tendon is subluxed to the opposite side, then it's a complete tear, is usually the way I handle it by MR findings.
And that determines what the surgeon does.
Okay.
If it's partially torn, you splint it. If it's completely torn, you may want to operate on it. In fact, you would operate on it.
Good. Thank you. Jennifer, National Hockey League player.
Right, so here we can see the soft tissue marker along the dorsal aspect of the metacarpal base, and there is some fluid signal along that visualized extensor tendon. I can't tell if it's a complete tear or just tenosynovitis on this image alone. And then here on the sagittal images, we can see that some of the extensor tendon looks intact, but there's increased signal and irregularity of the ulnar sagittal band.
Yeah.
And looks like there may be a tear of the sagittal band.
Yeah. And then here we can see the fluid going through there. That central part of the extensor tendons is a little bit subluxed over to the radial side, and this was a tear of the sagittal band with a little bit of displacement of the extensor tendon. And here's just a more prominent example from the literature of a sagittal band tear with displacement of the extensor tendon to the opposite side from the tear. Okay, Ashu.
So, former boxing champion, third metacarpal pain. So, looking at the third digit, you could see that there's disruption of the ulnar aspect sagittal band. There's not significant radial subluxation of the extensor tendon, but looks at least partially torn there. A lot of soft tissue edema there. I don't know if those exactly what I'm looking at here.
Yeah, this is just edema on both sides.
Okay.
And this was another tear. I don't know whether this was complete or just a high grade partial. Okay.
Okay, we have a soft tissue marker over the fourth digit. There's some edema around the extensor tendon there. Not sure which side is affected. Maybe the radial side is, yeah, just some edema there. Is that extensor tendon a little subluxed radially on the fourth?
this was a tear of the sagittal band, but this one was more complex because it actually involved both sides.
Okay, so it looks like we have dislocation of the extensor tendon of the third digit along the ulnar aspect. So I'm going to guess this complete tear of the radial side sagittal band. And so now we can see from the coronal view it's completely to the side of the metacarpal.
With dislocation.
So what would you do with that one?
Put it back in place.
That's a surgical one.
Yeah.
This what the hand surgeon wants to know. Is it displaced completely or is it not displaced? It definitely determines whether the surgery is done. And the reason it's important is because the healing in the hand of the tendons and ligaments, etc., is very, very long. And when you do surgery, the healing process is markedly increased. So you really want to be sure whether to operate or not. And if you operate, you know you're going to have a long process, like 12 weeks plus. If it's immobilization, you're talking about 8 weeks, a big difference. And then night splinting is even longer. So it's important to know these things.
Thanks, John. Jennifer.
Okay, so here we can see increased fluid signal intensity along the MCP joint. I can't tell if it's a tear of the extensor tendon itself or a tear of the sagittal band on this single image.
What do you think?
Oh, here we go. Probably sagittal band, since I don't see any retracted extensor fibers.
Well, why would it retract?
Okay.
Sometimes with a tear of the extensor tendon, there's proximal retraction.
Well, there is a little retraction, I think. I'm the orthopod, so you have to convince me now.
Okay, so
All right. Here on this image, it looks like the extensor tendon is intact.
How about?
And then one more image after this, we see absence of the extensor tendon. So this is a complete tear of the extensor tendon with a defect.
You see, I figured that out too.
Yep.
And that's why I asked you.
Complete tear.
One thing in law, if you ever go to court, when a lawyer asks you a question, he knows the answer.
Yep.
Same thing in with orthopedic surgeons.
Yep. Okay, Asher, what do you think of this one?
So a patient is unable to extend finger after trauma. We're looking at the second digit here. We can see that there's complete absence of the extensor tendon, so it's probably a rupture of the extensor tendon, extensor indicis. Here you can see focal fluid signal at the metatarsophalangeal joint, a metacarpal phalangeal joint along the dorsal aspect. At the extensor tendon, it's completely disrupted.
Yeah, so that's another tear.
So what would you do with that?
Then this is surgical.
Yes, it is. Would you wait? How long would you wait to do the surgery?
Not too long, I would guess.
10 hours. After 10 hours, interestingly enough, it becomes a subacute situation, a delayed healing. From 10 hours to about 8 or 10 days, is delayed healing. So it really changes things a lot, or can change things a lot. So it's important to do these as soon as possible.
Thanks, John.
And a big difference between in time with the hand.
Okay, we have a sagittal view here of one of the digits at the MCP joint. I'm seeing some mild volar subluxation of the proximal phalanx, lots of dorsal edema, there's a volar ligament, looks like there's a tear there.
So that actually was an impaction. This patient had significant trauma to the finger. This is a tear of the volar plate.
Okay.
Where this is the attachment of the capsule here. You can also see that, as you said, there's displacement here, big effusion, and some displacement. This patient actually had a hyperextension injury. That's what produced the tear of the volar plate in the anterior capsule, and it caused the impaction injury here of the distal metacarpal head from the displaced proximal phalanx. And then, okay. So then we can go on to zones 3 and 4. It's a proximal part of the phalanges and the PIP joints. You typically get extensor tendon tears in this location, and again, MR is very helpful. And here we can see the anatomy where the extensor tendon comes, and the center portion attaches to the base of the middle phalanx, the PIP, and then you've got the lateral components that split here, go around the insertion of the extensor tendon to the PIP, coalesce again, like we talked about before, into the terminal tendon, which terminates at the distal phalanx. So this is what it looks like. There's that central tendon, separation of the medial and lateral components around the side, coming back together and attaching to the distal phalanx there. So the anatomy here at the insertion is this is the tendon inserts on fibrocartilage here, which then attaches to the bone. We have fibrocartilage here at the volar aspect of the distal tendon. Tendon and bone don't like to rub against each other, and therefore usually where you have tendons where they rub against bone, you're going to have cartilage differentiation of the tendon in this location. And then you've got the synovial cavity here, and then synovial membrane and the extensor tendon. So here's an MR scan, here's a gross specimen, here's an axial MR scan, and this just shows the central slip coming here and attaching to the base of the middle phalanx. And there's the joint space right in through here. And then those medial and lateral components, that's the central slip. These are those medial and lateral components of the extensor tendon. They'll go distally, fuse again, and create the terminal tendon, which will then insert on the dorsal aspect of the distal phalanx. Okay, let's see, who's next?
Okay. So what we were just looking at on the gross anatomy, it looks like there's probably a complete tear of that central slip that's going into attach to that middle phalanx, where the black arrow is, and then on the axial view, we just see that we can see the kind of lateral slips, but then the central is just empty. Refused to for the distal.
So this is a tear of the central slip.
Now, I assume when you have something like this, you'd still have extension. So.
What do you do with this?
I guess you can kind of see how it's deformed.
You don't get extension of the middle phalanx.
Yeah, but you get the
distal phalanx. And so
It depends on in the ability to move it back in place. If it stays in place as you extend the length, you may you not do surgery, but if it stays this way, you operate and suture the slip. So it's you have to really know how much of a tear that is.
because if it's a large tear, what happens then is that if you try to extend, the forces go around either side of the proximal interphalangeal joint to the terminal tendon. What you then get is extension of the distal phalanx, but you don't get extension of the middle phalanx. And over time, if this becomes fixed, you end up with a boutonniere deformity, where you get flexion of the PIP and extension of the DIP.
That is absolutely correct, John.
Good. Okay, Jennifer.
But that's why it's important to be able to say whether it's a complete tear or not.
Yeah.
Okay, so this is a football injury. We have some sagittal and axial images, and there's increased fluid signal intensity and a defect just along the radial aspect of the central slip, concerning for a tear of the central slip.
And this turned out to be a laceration in this location. So now, as John was referring to, if you treat these right away, you don't necessarily have to have surgery. If you keep this splinted so you have normal anatomy and allow this to heal without getting a fixed displacement of the lateral components and extension of the distal one, a lot of these kind of tendon injuries can heal if it's properly splinted. And we'll talk about the terminal tendon treatments in a minute as well. But if that doesn't work, then you may have to do surgery. Okay, so that's central slip. Now, this.
You would, John, one thing though, in this particular case, you have a laceration.
Yes.
So you have to suture.
Okay, good. Thank you. Okay, and this whole area here is called the Extensor Hood, this whole complex that we're talking about. And then, which we can see here going across there. So this would be the central slip. This is all the extensor mechanism here, and there's the terminal tendon out there. Okay. And those are those lateral slips. That's a central one, kind of a, okay. And then here again, we can see a tear of that central slip. And again, abnormal signal, we don't see a normal attachment of the central slip, another central slip tear. And those are the medial and lateral components going around. Okay, see, you did the last one, right, Michael? Okay, Jennifer, what do you think of this one?
47-year-old male with third PIP injury. There are overlying soft tissue markers along the dorsal PIP joint, and there is increased signal intensity within the central slip, and it looks like a complete tear. There are some retracted fibers.
Okay, so there's one cut where we can see it. And then if we go a little bit farther out, we can see off to the side, we have increased signal intensity. And there we can see centrally there's increased signal intensity. And this turned out to be a complete central slip tear with a little retraction there. Okay, Ashu.
What was that displaced, John, on the last one?
A little bit, yes, about 3 millimeters.
And then you'd want to fix it.
All right, so we're looking at the third digit. I'm guessing along the lateral slips there, there's a little bit increased signal. I'd like to scroll in and out to see how they look, but
Yeah.
okay, so they're just sprained. Okay, just increased signal.
Of the collateral ligaments of the joint itself. This wasn't a tendon injury. This was a PIP dislocation, and you got capsular injuries from the dislocation, and it relocated again. But the tendons were fine. And then if we go distally, we have zones 1 and 2, which is the middle phalanx and the DIP joint. Again, the common problem here are extensor tendon tears in the extensor compartment, and this is where those medial and lateral slips come back to form the terminal tendon, which attaches to the distal phalanx. And here we can see the gross anatomy of the terminal tendon coming and attaching to the bone. And this is what the MR scan looks like in the sagittal plane.
We're seeing a sagittal view of a DIP joint. The arrow is pointing at where that terminal tendon should be. I'm not seeing it attached to the distal phalanx tear.
So this is on a graded echo sequence.
A 6-year-old male was swelling for 3 weeks, no trauma, rule osteomyelitis or tear. So similar appearance. We can see the terminal extensor tendon going towards the distal phalanx, but then we see a gap filled with fluid. So it's torn and slightly proximally retracted.
Yeah, I like to follow these on the axial images.
Mm-hmm.
The sagittal is a nice plane for it. Okay, Jennifer.
Here we can see cortical irregularity along the dorsal aspect of the distal phalanx where the terminal tendon attaches, and there's some anterior subluxation. This may be seen with a mallet finger.
Yeah, it's actually, I don't think it's dislocated so much or subluxed. It's just flexed at this level. Yeah, and this is a mallet finger. And these are typically due to either a bony avulsion at this location or a tear of the terminal tendon. And I've seen a number of these. In fact, I've seen some of the last one of these I saw was in a friend of mine who's a professional violinist who tore this. And after seeing several different hand surgeons, they elected to treat it conservatively. He couldn't play for about 3 months, and it was splinted, and it actually healed. And after 4 months, he was back playing professional violin again without a problem. So, but if you continue to flex it and don't allow it to heal properly, then it turns out to be a mallet finger where you can't extend the distal phalanx.
The treatment is much longer these days than it used to be. It's up to 12 weeks, and then night splinting. So it's a prolonged process if you want a normal finger.
Yeah.
If a mallet finger usually will not cause you any great difficulty unless you're a violinist.
So let's go on now to the flexor side. We'll look at the carpal tunnel, the neurotendon tears, the MCP problems, and we'll go into the fingers. So carpal tunnel syndrome is really pain and swelling and discomfort in the region of the carpal tunnel with often neurologic problems going more distally. Etiology, it's typically due to chronic repetitive trauma, typically seen in typists or people who do a lot of flexion of the wrist. Can be seen in inflammatory disease such as infections or a rheumatoid arthritis. It can be caused by instability of the wrist, by masses in this location, and then it's also something that's been described in swelling with pregnancy. Let's see, Ashley, what do you think of this case?
It looks like there is a disruption of the flexor retinaculum of the carpal tunnel or the transverse ligament there. There's some edema kind of superficially, but that's maybe there's a little bit of enlargement of the median nerve right there. Maybe an increased signal there is a little bit as well. It might have been a laceration injury, and it might have been partially injured there. And you can see a lot more soft tissue edema and disruption of that flexor retinaculum, I think, at that level.
So the history is
on the sagittal images.
Most of the time when we see something like this, it's going to be post-surgical with
Okay.
a release, but this actually happens to be a laceration from glass. And the problem here is this is not a normal median nerve. So we were very concerned about injury to the median nerve here. So that has to be carefully evaluated in laceration injuries like this, both injuries to the nerve as well as to the flexor tendons.
Usually, though, if you do have a post-surgical, release, isn't it usually not that big of a defect? Usually, like I've never seen it that big of a defect, but usually scars in pretty fast.
There are all kinds of sizes. Some people will completely remove all the flexor retinaculum. Some people will just make a slit in the retinaculum, and we'll talk about that later.
One thing we know is that this is not a suicidal attempt, because a lot of people will lacerate their median nerve by trying to commit suicide.
Right.
Slicing their wrist, but of course the slice would go a different way. I had a patient like that I'll talk about later. Okay. If John will let me, of course.
Absolutely. You can do it now or later?
Well, since I brought it up, might as well
go for it.
About it. I had a gal come in and she, pardon me?
Go ahead.
Oh, okay. I had a gal come in to my office and she said that she tried to commit suicide 5 years before. And she had some difficulty with her median nerve. And I looked at her and I really didn't see very much other than some atrophy and a thinner eminence. And there was the otherwise, the wrist looks pretty good. Anyway, I sent her for a physiological testing, and her results came back normal in terms of function. And I obviously knew that it wasn't normal. The Phelan test was positive. The percussion test was positive. Wrist squeeze was positive, and there was atrophy, etc. So anyway, I operated on her and repaired the median nerve. She had one little fiber of nerve that went to the thinner side, and that was it. Of interest is I'm not a hand surgeon, but I did find the scar and repaired it, and she came out like over 90% function without any neuroma. It was a very interesting case because I found out one thing for sure is don't trust physiological testing.
Okay.
We had no MRIs in those days.
Okay, good, John.
She was a happy lady.
Fantastic. So here we can see this is kind of a normal flat flexor retinaculum and on the carpal tunnel. Here's an abnormally bowed flexor retinaculum we see here with a little bit of synovial thickening in through there. This is the other patient with PD and PD fat set. PD and T2 weighted images. Okay. Let's see.
We have an axial view through the carpal tunnel here. I'm not sure. I mean, what catches my eye is this structure in the carpal tunnel there. It's kind of geometric. Yeah. I mean, it could be. Yeah.
These are all fat suppressed sequences.
I mean, if it suppresses maybe lipoma. I'm not sure if there's lipomas in the carpal tunnel, but oh, that muscle.
So if we go back to this again, what we're seeing here, the other thing that this can be, this also has the same signal intensity as muscle. As we talked about before, occasionally what you can have is muscles that extend too far distally into tight areas, and this is actually a variant where the muscle, one of the flexor muscles, instead of stopping back where it's supposed to and just having the tendon go through this area, the muscle goes actually through the flexor retinaculum, and there's not really enough space there for a muscle because the muscle is not supposed to be there. This is anomalous flexor digitorum superficialis muscle, which goes to the index finger, which was producing symptoms. Here's another example of an abnormal, again, this has signal intensity of muscle, so kind of a normal muscle, but an abnormal position here, extending along the tendon. So these, just be aware of this. They can occur all kinds of different places, and as you've seen just in the last few weeks, there have been a couple of clinical examples that we've had here of people not recognizing these when they were actually the cause of the patient's complaints and concern. So just remember that going forward.
You would think that the patient would feel that, John. I'm surprised that an adult wouldn't know that they had something abnormal in the wrist.
Well,
by movement of the wrist, etc.
Well, recently, my best friend's son came in with a mass on his wrist, and it was easily palpable, and it also caused symptoms, which actually worsened when they put a splint on it over it, and they got an MR scan that was read as normal. And when I looked at it, what it was just another one of these muscles. It was on the dorsal side, but it was a muscle in an abnormal position, a muscular variant, which was actually producing the palpable mass that the patient was concerned about, and the symptoms from kind of compression when they tried putting the wrist in a splint. So the problem is that there are not a lot of radiologists who recognize that this can be a problem, and it's not that common. But you can see it in anywhere where these tendons, where muscles extend along tendons. We see it not infrequently in the ankle, as we talked about before, but certainly in the wrist we can see it. We can see it in the elbow and other places, as well as the shoulder.
Usually, if you have an abnormal muscle like that, it's picked up early, probably in childhood. And so that's why we don't see them later on.
Okay.
I've personally never seen a case, and I've seen a lot of children with problems. So you're right, John. It's just a very unusual condition.
And
you have abnormal friends, John.
yeah. Well, we probably see it more also with MR because we can see these particular areas, and some of these are maybe a little bit hard to palpate.
So 22-year-old male sickle injury. So in the carpal tunnel, we see this kind of well circumscribed structure that, like the other case, looks like it's iso-intense to muscle on both images. So I don't know if the injury is just like kind of a red herring. The median nerve, the retinaculum, I think look okay. So looking along this, it does look like there's a muscle belly which extends along through the carpal tunnel. So I don't know if it's just another flexor digitorum superficialis.
So when we're looking for carpal tunnel syndrome, we look for splaying of the flexor tendons due to increased synovial structures within the carpal tunnel, as well as bowing of the flexor retinaculum, indicating chronic increased pressure within this particular compartment. The other thing you look for is if you have a constriction at the level of the retinaculum, what you will develop, which is common with a lot of nerves, is you can get hypertrophy and edema within the nerve proximal to the constriction, because the constriction, the pressure, inhibits a normal flow of fluid along the nerve, and you can get enlargement of the nerve proximal to the problem. And this is very similar to what we see more commonly in the foot, where we have Morton's neuromas, which is a kind of similar kind of problem where you get chronic pressure on the interdigital nerve, which injures the nerve, and we can see enlargement of the nerve, which is the same sort of swelling that you see proximal to an area where you have constriction of the nerve.
So you get a little bit of like an hourglass,
right,
appearance.
And so this is often called an hourglass nerve. Sometimes you can see that hourglass appearance on the coronal images, where it's enlarged proximal, very narrow in the area of constriction, and then enlarged distally. And this is a typical edema pattern of the median nerve. So here we can see proximally a large edematous type median nerve at the level of the flexor retinaculum. It looks a little bit more normal, but this is another thing you look for in patients who may have symptomatic carpal tunnel syndrome. And this just shows enlargement of the nerve, edema within the flexor tendon sheaths, kind of squeezed here at the level of the carpal tunnel, and then it's also a little bit enlarged distally, which would be a abnormality. So the MRI criteria for carpal tunnel syndrome from this particular paper is you look for cross-sectional area of the median nerve, should be enlarged proximal, maybe small in the carpal tunnel, and large distally. You get bowing of the flexor retinaculum. You can do a flattening ratio between proximal inlet and the outlet of the median nerve, but that in this particular paper is shown not to be significant. And then the ratio of the cross-sectional area at the inlet and outlet, and relative signal strength, where you get edema if you have constriction of the nerve. What they found most useful is if you look for the let me see.
Cross-sectional area?
Cross-sectional area. So if you look at the cross-sectional area at the inlet, if it's greater than 15 millimeters square, it's abnormal, and if it's greater than 19, it's typically considered severe. So you kind of look at the history of physical exam. You can look at electrodiagnostics, like John was talking about, and typically, according to this article in JAOS, Journal of American Academy of Orthopedic Surgeon, is that imaging is not routinely indicated. But what I found that certainly if it's to a point where people are considering surgical treatment, it's common to get imaging, but there was a lot of surgery done in the past without imaging. This kind of surgery could be done very readily. I knew a surgeon who used to do 20 a day of carpal tunnel release surgeries. The problem is that some papers came out a few years ago showing that the outcomes weren't great, and we'll talk about that in a minute. So now most insurance companies will not pay for carpal tunnel release surgery.
I completely disagree with this fellow.
Which fellow?
Keith.
Keith, okay.
American Academy of Orthopedic Surgery. Usually they publish pretty good papers, but this one I'm gonna cross out as BS.
Well, this was 2009.
I know, 2009, that's BS.
Okay.
Imaging is more important maybe than some people's examinations.
Okay, good. I forgot who was last. I don't know. Jennifer, why don't you take this one?
So we have a 49-year-old female with pain for 2 years and pain at night.
So this is ultra noise, and this is through the carpal tunnel.
Okay, so here we can see increased vascular flow within the carpal tunnel that demonstrates arterial flow pattern, which is concerning for a persistent median artery.
Okay, here's the MR scan.
Here it does look like there is an extra rounded structure just superficial to the median nerve. This is probably a persistent median artery. And then here we have some angiogram images showing vascular flow of the persistent median artery.
Yeah, so what you can have, you can get a bifid nerve, and it's often associated with a persistent median artery, just like you're saying, going through the carpal tunnel, which can increase pressure and increase size there. So there are other anomalies of the median nerve in this location that you can look for. I've not, though I've seen a couple of cases where they say that there were accessory arteries in through this area, as we see here. I've not found them readily apparent on MR. And the only thing I can guess is maybe there's enough constriction in space here where there's not adequate flow to allow us to get flow artifact to be able to visualize them on an MR scan.
At surgery, one thing we do is make damn sure that you see what you're cutting. You don't want to cut any of these vessels, and especially not the median nerve that goes to the thumb.
Okay. And this shows kind of the normal anatomic pattern. And then this is one of the number of anomalies where you can have a bifid median nerve with the persistent artery going through the center of it that you have to be careful of. And the anatomic relationship can be very variable between the persistent artery and the nerve. So you have to be very careful.
That's probably pretty unusual, isn't it, John?
Well, here it says between 10 and 23%. I certainly haven't seen anywhere near that number by MR, but I think we best not. I don't think we can visualize the majority of these.
Well, I think this would be surgical writing, not radiological. But there's a big difference between 10 and 23%.
Yeah, that's certainly.
I don't know how they come up with that kind of figure.
Yeah, I guess different papers with different patient populations. Okay, Ashu.
All right, so 53-year-old male with right second, third finger tingling sensation for 3 weeks. So has clinical symptoms of carpal tunnel. Looking at this, within the carpal tunnel, the median nerve looks enlarged and abnormal. I don't know if there's something else within the median nerve. So it looks like it's.
Yeah, I really find that only looking at fat suppressed images, though you can see the edema is fine, it's a little bit often misleading because the fat really is a great contrast agent. So I think it's always important in the hand and wrist to make sure you've got a non-fat suppressed and a fat suppressed images together. One looking for the edema pattern, the other looking for the details of the anatomy using fat as a great contrast agent. So here is a T2 weighted image, which is non-fat suppressed, and this is a T1 GAD on the right.
All right, and here we can see that there is the median nerve. it looks bifid. Almost feels like there's two separate components of the median nerve right there. And then there seems to be some increased enhancement of one portion of the median nerve. Although this looks like there's some flow. Is this a persistent median artery with thrombosis? Because it doesn't. Yeah, that's what I thought. Because
Very good. Yeah, so that's persistent median artery and the thrombosis, which is why you don't see uniform flow there. And again, this just shows that you can have multiple different configurations between the nerve and the persistent artery.
Congratulations.
Yeah, very good diagnosis. Yeah. And it can become thrombosed due to the increased pressure in this area, restricting flow.
I'm going to give this guy an extra pen, John.
We're seeing the carpal tunnel here. I see bowing of the flexor retinaculum, concerning for carpal tunnel syndrome. The above image, I'm not seeing the flexor retinaculum as clearly. Maybe it's post-surgical. Oh, okay.
We're seeing there's a lot of fluid around the tendons, and then here we can see fluid around the tendon sheaths as well. And this is the carpal tunnel that's through here. You can see the fluid pooling proximally and distally. What would you call this?
I'd call it tenosynovitis. Yeah.
So this is tenosynovitis. And then the differential is kind of overuse, where you get irritation of the synovium and increased fluid. Inflammatory conditions such as rheumatoid arthritis or psoriatic arthritis, or infections. And infections in this locale, hopefully we'll have time to go through some of them here. The ones I've found most common that look like this in our area really are two: either atypical mycobacterial disease, which could be more of a chronic kind of condition, especially Mycobacteria avium. I've seen it a couple of times in TB, and then valley fever, coccidiomycosis. I've seen present like this a number of times from our imaging centers out in the desert. So remember those. And those are more of a chronic type, indolent type infections, which may not present like you might expect a typical Staph aureus or something. They may be, the symptoms may not be quite as severe. Other things to look for in the carpal tunnel.
Okay, so on this axial image, it looks like we have this circumscribed hyperintinge structure, same as fat. I'm not sure if this is this T2 image, so it's not sure if that's fluid or fat. So it could just be, if it's fluid, just a little ganglion,
Surprisingly, a fairly common location for ganglion cysts, even though this may be a high pressure area. And when you have it, this takes up more space, increasing the pressure, and we actually see a little edema within the nerve here. This is a very old image in the early days of MRI imaging. Here we can see is a more degenerative cysts extending into this area, producing pressure, increased pressure in the carpal tunnel area, maybe some compression of the median nerve. And this patient also presented with carpal tunnel syndrome, but the cause of this was actually the degenerative disease of the wrist and these cysts that come out from the joint space in this location. So don't forget these as also a not uncommon cause of carpal tunnel syndrome. Jennifer.
Okay, so we have two axial images of the wrist through the distal carpal tunnel. Again, we can see some fluid signal intensity along the deep aspect of the carpal tunnel, which may represent a ganglion cyst.
Okay. And here's another example of cysts in this location. These typically come from the joint space and producing symptoms. Ashu.
So 55-year-old male with carpal tunnel syndrome. We have two coronal images here. I see radioscaphoid ganglion cyst, but I don't know if that's what the finding is.
Here we can see those volar thickenings of the capsule, which are the volar capsular ligaments. We can see the fluid collection in that location. Here's a gradient echo in that area. Here are the axial images.
Okay, so looks like there is a mass within the carpal tunnel, causing some flat.
That's this thing right here.
Okay. Oh, and then it does fat suppress. So is this just a lipoma?
And that's another not uncommon cause of carpal tunnel syndrome, or I guess uncommon, but not extremely rare, is a lipoma inside the carpal tunnel. In fact, there is a type of lipoma which is very characteristic of the carpal tunnel, which hopefully we'll get to here in a minute, I hope. And here's another carpal tunnel lipoma. Here, this one is not associated with the median nerve. So these are carpal tunnel lipomas, which increase the pressure and can lead to carpal tunnel syndrome.
Looking at the carpal tunnel here, we see, I can't make out the tendons that well.
So we can't make like tendons. This is another old study. Here we can see the bowing of flexor retinaculum. What's all this stuff here? There. Go to another image is this thing. Here's another image is this thing.
No, I don't know.
So I'm sure you've all heard the term mini, right? Okay. So this is one of the Aunt Minnies of musculoskeletal imaging. And if you look at this, it looks like it's got kind of fatty fibrous tissue in it. If you follow it, it's actually, this is enlargement of the median nerve. So what do you think it might be?
Oh,
Hamaratoma. Hamaratoma. This particular location, and it's splaying. Now, so it's considered a hamartoma, so it's normal neural elements, but in an abnormal configuration. And I've seen a few of these in other locations as well. The common finding between all of the ones that I've seen in the musculoskeletal system, they've all been in areas where there are some sort of a fibrous retinaculum which constrains the volume through which the nerve goes. So I think a lot of these may be just due to chronic irritation of the nerve. In essence, it may be a little bit like a very large Morton's neuroma in this location. So
Hamatomas have some interesting substances in them. Some have hair, cartilage, and other things. They're a weird kind of a
yeah, I'm not aware of these having other structures like hairs, like you can get in pelvic hamartomas and things. But that's right, they can be weird. But anyway, this is kind of an Aunt Minnie. If you see a very large, enlarged median nerve with kind of lipid elements in it, it's a fibrolipomatous hamartoma.
I'm not talking about the nerve itself, John. I'm talking about what you can find in a wrist.
Yeah.
Yeah, that puts pressure on the nerve.
Mm-hmm. Okay. Okay. So, Michael, this is a post-op case.
So this carpal tunnel post-op. I do see some kind of low intensity soft tissue kind of along the the edge of the carpal tunnel. But the flexor retinaculum overall, like, I see kind of a band going completely across. So I don't know if it's, if they've done a release and it's just scarred down, or if they kind of missed it.
There are a number of kind of releases. One that there was a surgeon I worked with for a long time who did a large number of these, where he would just go in and slice the flexor retinaculum and then leave it to scar in. And what we found with those is almost always within 6 months, the retinaculum would again be intact, and we would just see the scarring above it, around it. But often there would be increased scarring, which would also envelop the median nerve. And a lot of those patients' symptoms got worse as they developed more scar tissue. This is another kind. This is a larger, where they actually took a defect out of the flexor retinaculum. These take longer to scar in and heal. We can see the median nerve there, but there's scarring around it because we don't see the margins of the median nerve very well in this particular case. And so this is really a partially resected retinaculum rather than just, and then this is one where they really excised the retinaculum completely, and it's starting to scar in here with this thick band of scar tissue. And there again, we see scarring around the median nerve, which we don't see the margins of the median nerve very well.
That's not recommended. I've done my share of these, and the main thing is you make sure that you do a complete incision of the fascia. The problem with a lot of cases is the doctor will try to do a transverse incision and not get a good view. Now there are instruments available where you can insert into the carpal tunnel canal and see everything clearly and get a better result. So there has been some progress in doing this surgery. Overall, carpal tunnel, if you're not dealing with workman's comp, you can get a pretty good result if you treat the proper patient.
Good.
The biggest problem is workman's comp, and John can tell you about that.
Yes. John and I have both worked a lot in medical legal aspects of workers' comp.
None of the cases I've ever seen in workman's comp got a good result.
Yeah, well, the motivations of the patients are different in workers' comp than they are in traditional medicine. So, right.
And a lot of people will undergo surgery for money. It might be difficult to believe, but it's true.
Yeah. That's it.
I've seen quite a number of cases that did that.
Yeah. Yeah, there are a lot of problems with our healthcare system, and one that by dividing the healthcare into different components, like workman's comp is different from other types, it causes a lot of bizarre decision making that's not always in the patient's and society's best interests, and money tends to be a big driver in those particular areas. Well, why don't we stop here, and we'll pick up and talk a little bit more about different surgical things with carpal tunnel syndrome at our next lecture. Any questions?